Well, our next speaker is Dr. Case Wood. He joins us from Low Country Urology Clinics. He is a urologist and was kind enough to be willing to speak about a topic that we deal with day after day. What do you do about prostate issues? Do you screen? Do you not screen? And if you are screening, when do you stop? And then, of course, that constant, as you're leaving, conversation of erectile dysfunction. So with no further ado, I'll turn it over to you, Dr. Wood.
Well, great. Well, good morning. Thank you for the opportunity to speak, and that was a generous introduction. So again, specifically today, excited to talk to you all about men's health, which is a big focus in my practice, and we're going to really focus on prostate cancer and erectile dysfunction. No disclosures with my talk today. The objectives here, so we're going to talk about prostate cancer, 20 minutes or so we'll spend. We'll review the, the most updated guidelines and rationale for prostate cancer screening. We'll spend some time discussing the initial diagnosis and management strategies for newly diagnosed prostate cancer. And, I think it's important that, especially those of you in primary care, really have a good working knowledge of the different types of treatment decisions that patients face as a result of their decision to ultimately undergo prostate cancer screening. And then, as was alluded to, it's impossible for a urologist to get through any discussion, whether it's formal or informal, without discussing erectile dysfunction. So we'll spend some time talking about erectile dysfunction. Again, we'll review the guidelines for diagnosis and medical management, and we'll try to touch on some potential practical treatment strategies. Now, some epidemiology. Prostate cancer, the most commonly diagnosed cancer in men. There's about 170,000 diagnoses made annually. This is diagnosed in 1 in 7 men in their lifetime. The mean age of diagnosis is around 67, but of course, prostate cancer screening typically begins much earlier in life than that. Prostate cancer is commonly low risk at diagnosis, but there has been a more recent trend towards migration to a higher risk disease at the time of diagnosis. And this is likely the result of a much narrower screening guidelines, and we'll discuss those in detail. Additionally, there are certain risk factors associated with prostate cancer that should be factored in when deciding who and when to initiate prostate cancer screening in. Specifically, patients that have a strong family history, so first-degree relative, father, brother, with prostate cancer, especially lethal prostate cancer. Patients with germline mutations, specifically BRCA1, BRCA2 germline mutations, so those patients that have a strong family history of breast or ovarian, pancreatic cancers, these should be considered in the workup. And then lastly, African American race. Men of African descent certainly have an increased incidence of prostate cancer in the U.S. There's about a 60% increased risk of prostate cancer in African American men compared to Caucasians. Additionally, there's about a 2 to 3 times higher rate of death in comparison to Caucasians. And of course, prostate cancer screening hasn't been without controversy. You're all aware of this. The U.S. Preventative Task Force Service assigned a grade D recommendation of prostate cancer screening in 2012, essentially recommending against it. And this was met with certain criticism, certainly. And in 2019, this was ultimately amended to a grade C recommendation for a specific age group of men, and we'll talk about that in detail. Now, the goals of prostate cancer screening, what are we really trying to accomplish here? We're trying to detect potentially lethal prostate cancer at an early stage with the goal to intervene with curative intent and minimize the burden of treatment overall. That's the whole goal of screening, and that's why we do it. And the screening tools that we use are PSA. That's something I'm sure you're all aware of and implement into your daily practice. Digital rectal exam, or DRE. And then there are some additional adjunctive screening tools we'll talk about a little bit, so prostate MRI or other biomarkers. And we'll touch on each of those. Now, we'll start with PSA, prostate-specific antigen. This is a protein enzyme that's produced by glandular tissue in the prostate. Its real role is in the seminal fluid liquefaction. It's thought to play a role in the dissolution of cervical mucus. And PSA concentration in the serum is typically very low, but it can be increased in certain settings. So inflammation or infection, for example, trauma to the pelvis or the prostate specifically, potentially after catheterization. BPH, certainly an enlarged prostate gland, has more glandular tissue, produces more PSA that's absorbed into the bloodstream. And then, of course, prostate cancer. So those are the common reasons why PSA can be elevated in any specific patient. What is interesting, though, is that prostate cancer cells actually produce less PSA relative to normal prostate cells, and that's thought to be due to the disruption of the basal layer, allowing essentially for more leaching of PSA into the serum. Now, in an effort to avoid falsely elevated PSAs that may prompt additional workup that a patient might not need, it's important to take some of these factors into account. So PSA testing should really be avoided in a patient with a recent urinary tract infection or suspicion for prostatitis, maybe a patient that has had a recent catheter placement. Additionally, it's recommended that men abstain from ejaculation at least 48 hours before a PSA is collected. And there's actually decent data to support that within this time frame that PSA can be statistically elevated. And it's also noteworthy that PSA values in men that are taking 5-alpha reductase inhibitors, so finasteride is the common example, that these PSA values should be doubled when interpreting these for screening for prostate cancer. And it's also important to know that whether this is at the 5 milligram dose of finasteride used for BPH or at the 1 milligram dose used for male pattern baldness, the number should still be doubled, even at the 1 milligram dose. Now, an important yet inconvenient part of prostate cancer screening is the digital rectal exam, or the DRE. But this is a really important component of the overall evaluation and screening process, because prostate cancer, for one, it rarely presents with symptoms. Very rarely are people presenting with urinary symptoms as it relates to a prostate cancer diagnosis. Prostate cancer typically affects the peripheral zone, or the posterior part of the prostate gland, and so this can be easily palpated on exam. And then digital rectal exam represents a big part of the clinical staging component that is used for further risk stratification. So an important part of the screening process. Now, in addition to PSA and DRE, prostate MRI is an increasingly valuable tool, something that I commonly use in my practice. It utilizes a specific sequence imaging protocol that essentially identifies potentially clinically significant prostate cancer lesions within the prostate gland. And these are scored based on a PI-RAD system, not unlike the BI-RAD system used in mammography. Now, MRI of the prostate gland can be used in a couple of different ways. It can be used as part of the initial screening process. And the advantage there is that, MRI is not a supplement for prostate biopsy, but it can potentially spare patients additional prostate biopsies. And so the example is a patient that undergoes a routine prostate biopsy after an elevated PSA, and that biopsy comes back negative. Well, generally speaking, we're thinking about getting a MRI of the prostate gland to rule out any lesions that might have been in an area of the prostate that weren't sampled at the time of biopsy. And so one strategy for avoiding potentially a second prostate biopsy is to evaluate the patient with an MRI up front. And if there are lesions outside of the normal areas that are targeted with prostate biopsy, then these can be specifically targeted using a specific sequence and software imaging at the time of prostate biopsy. And so this is, again, commonly something that I implement into my practice, and I suspect that because of the utility of this test, I think that it's going to be likely found in some of the screening guidelines in the future. Now, also available, I mentioned these earlier, other biomarkers. I suppose PSA is technically a biomarker, but there are adjunctive biomarker tests available that are marketed, and they can be available through urine samples or serum samples. Additionally, we use tissue samples after prostate biopsy to further assess the clinical significance of certain types of pathology. Now, I've listed here some of the most updated prostate cancer screening guidelines, and this is from both the American Urologic Association and the NCCN. And notably, the AUA guidelines support a shared decision-making approach for men between the ages of 55 and 69 at average risk, so no identified risk factors. But you know, in reality, PSA screening and prostate cancer screening can be considered in men really as early as the age of 40, especially if they have identified risk factors. And then I'd like to point out with the NCCN guidelines that prostate cancer screening is generally recommended at the age of 45. So you already see some variability between, you know, two of the more common prostate cancer screening guidelines. And the point is not necessarily that you should choose one or the other, but just be aware that there are differences out there and that none of them are wrong. So once the screening process has been initiated and a concern for clinically significant prostate cancer exists, the next step is generally prostate biopsy. And as I mentioned, prostate biopsy is performed through a transrectal ultrasound approach, generally speaking, where the needles actually pass through the rectum. And this is the standard of care really to date, or via a transperineal approach. And this has gained some traction in more recent years, really an effort to try to reduce the risk of infection associated with prostate biopsy, which is ultimately low. And now, as I mentioned earlier, prostate MRI is often incorporated at the time of prostate biopsy, and this is again to really try to identify lesions outside of the typical areas that are sampled at the time of a standard prostate biopsy. This procedure is performed either under general anesthesia or awake, potentially in the office using just local numbing medicine. The risks associated with prostate biopsy are ultimately low, but not zero. So there's a risk of infection. This is what we really worry about the most, generally speaking. Somewhere in the 3 to 4% of patients that undergo prostate biopsy will have some degree of infection following the procedure. We make efforts to reduce the risk of infection following prostate biopsy by giving patients antibiotics, typically a fluoroquinolone antibiotic, prior to the biopsy, and we also use a fleet enema to clean the rectum out prior to prostate biopsy. But ultimately, even with these precautions, the rates of infection are around 3%. And patients can become systemically ill in the setting of a prostate infection and require hospitalization. So it's really important that they be aware of that and that they follow the pre-procedure protocols. Bleeding is a risk, albeit mild. There's the risk of bleeding in the stool. We see some blood in the urine. This is typically, again, mild and short-lived. We do typically see blood in the sperm, or in the semen, I should say, and that can last for weeks after a prostate biopsy and is generally expected. And then lastly, I suppose there's a risk of diagnosing low-risk disease, particularly in our older patient population. And you know, low-risk disease or otherwise clinically insignificant disease is a burden to patients because there's generally additional follow-up or diagnostic studies that are considered, not to mention just the psychological burden of treatment. Now, following prostate biopsy, we ultimately get pathology results to discuss with patients, and typically it's either benign or represents some variation of prostate adenocarcinoma. Rarely we get more atypical lesions that might require a repeat biopsy, but in general, the aggressiveness of the disease is assigned by a pathologist, typically based on a Gleason score, and then assigned a grade 1 through 5, based on the Gleason score. And this is typically a little bit easier for patients to interpret as you're discussing the risk stratification. And here is the current AUA risk stratification. And so again, just to point out, prostate cancer is a spectrum of disease. It's not one specific diagnosis. It ranges from very low risk prostate cancer that can be simply observed, and we'll talk about all of the management strategies shortly, all the way to high risk prostate cancer that can be potentially aggressive and lethal. And so these are managed very differently. But you see, based on the AUA risk stratification, that we're incorporating a lot of this information into this risk stratification. So not only the PSA value, but the digital rectal exam to assign a clinical grade, as well as the pathology. Now, given the typical latency between prostate cancer diagnosis and risk of prostate cancer mortality, it is an important factor to consider a patient's life expectancy, prior to initiating prostate cancer screening, really. And as a reminder, and looking through some of those guidelines earlier, generally speaking, men with an expected life expectancy of less than 10 years, it's not recommended to initiate prostate cancer screening. Now, in my practice, I commonly utilize the Memorial Sloan Kettering prostate cancer life expectancy calculator, and this is a really great tool. It provides a lot of clinical context for patients that they can easily interpret. As an example, I've plugged in some typical risk factors that might be seen in a patient in my office, and so we have here a 69-year-old male who's had a biopsy already. He's diagnosed and stratified with favorable intermediate risk prostate cancer. His other risk factors include hypertension, hyperlipidemia, atrial fibrillation, and he's a former smoker. And so what's really important here is to see that at 10 years, which is that first column on the left of the screen, 53 of the 100 men would be expected to be alive at this point. Only 7 men would have been expected to die of untreated prostate cancer. The remainder of the 100 men would have been expected to die of another cause. Likewise, at 15 years, 28 out of the 100 men are expected to still be alive, while only 10 might have died of untreated prostate cancer. And again, this gives patients a lot of, I think, clinical context into how we think about prostate cancer and the risks. We don't want patients to leave our office thinking that they have been diagnosed with favorable intermediate risk prostate cancer and that they're gonna die. So prostate cancer management. Once a diagnosis has been established and the risk stratification has been performed, it's really time for the patient and the urologist to decide on a management strategy. And this can include active surveillance, this can include curative treatment options such as surgery or radiation. For the patients that are diagnosed with more advanced or metastatic disease, we think about alternative treatment strategies. And then specifically in the older patient population who may have been diagnosed with prostate cancer, we often consider a watchful waiting approach. Now, we'll start with active surveillance. This is generally reserved for patients with very low risk and low risk disease, and it's an excellent strategy. The benefit is really to avoid or delay potential side effects of treatment while closely monitoring for any evidence of disease progression. The active surveillance protocol typically involves a prostate MRI sometime within the first few months following their initial diagnosis. And what we're really looking for there again is potentially clinically significant signs of prostate cancer, potentially outside and something that may have been missed on an initial biopsy. Additionally, patients will require a confirmatory prostate biopsy, usually within the first 6 months to a year. And this is to really give as much information about the stage and grade of their prostate cancer as possible before really committing to an active surveillance protocol, which ultimately includes continued PSA monitoring and digital rectal exams, generally every 3 months. And often over years, we may consider repeat imaging studies and biopsies. Now, men with clinically localized disease, generally low or intermediate risk prostate cancer, sometimes high risk prostate cancer, we consider curative treatment options, and that really comes in 2 flavors. Surgery to remove the prostate gland, and this is done almost exclusively these days by a minimally invasive approach, typically robotically, which is what I do and what I offer patients, or radiation. And what's important for patients to understand about these 2 options is that they are different in the way that you go about the treatment, obviously. There's potential subtle variations in long-term side effects associated with each modality of treatment. But in terms of the ability to cure a patient of prostate cancer, they can be considered comparable. And so there's really no wrong way to go about this. Now, certain patients may favor surgery for one reason or the other. Certain patients may not be surgical candidates at all, in which case they are generally steered towards radiation. But again, the cure rates for prostate cancer, assuming it's clinically localized, are generally quite high. The prior patients' same risk factors are plugged into a similar calculator, and you see that at 15 years, there's a 99% cancer-specific survival. And that can really be translated into radiation treatment as well. It's quite good, and so these are really great treatment options for patients who elect to do that. Now, finally, when it comes to advanced prostate cancer, there are really two categories of men. Men who present with de novo metastatic disease at the time of diagnosis, meaning that they've undergone their initial staging workup and identified disease outside of the prostate gland, or men who advance to metastatic disease following localized treatment with curative intent. And this is a topic that's largely outside of the scope of today's discussion, but this is not something that can generally be cured. This is something that is managed and treated to slow progression and minimize symptoms. And so, wrapping up prostate cancer here, in summary, prostate cancer is common, but it's rarely lethal. Again, the overall goal of prostate cancer screening is to potentially detect clinically significant or potentially lethal prostate cancer at its early stage, offer curative intent treatment, and minimize the burden of those treatment options. Important to identify prostate cancer risk factors in patients, specifically African American males, those with a family history, potentially germline mutations. PSA and DRE remain the gold standard for prostate cancer screening, and you should make efforts to avoid obtaining a falsely elevated PSA. Screening generally involves a shared decision-making with the patient and the physician, and can be initiated at patients above the age of 40 with associated risk factors, or around the age of 50 or 55 with men of average risk. But we generally do not recommend screening for prostate cancer of men who have a life expectancy less than 10 years. So if we've had any questions come in on prostate cancer, I'm happy to touch on those now. We can do that at the end.
We do have a couple of questions.
Sure.
One is a great question to me. How should a PCP be managing mildly elevated PSAs? We all see those folks that either have a little faster incline or it's just maybe 5.
Yeah, that's a great question. And I think to some degree it's individualized based on the patient. So PSAs are valuable screening elements, and the more PSA values you have, the more valuable these PSA numbers become. In other words, when you can really establish a long-term trend of PSAs and you see a gradual increase in PSAs, that is generally more concerning to me than a PSA that fluctuates over time. In other words, if you see a man who has a PSA in 2018 that was 5.3, in 2019 it was 3.5, in 2020 it was 4.1. Those sometimes can just be an indicator of BPH or intermittent inflammation, and I think it's probably worth screening those patients, or at least considering referring to a urologist. I would talk about probably obtaining an MRI in a patient like that, and then having a more thorough discussion about proceeding with diagnostic steps such as biopsy.
Also, a question saying, any guidelines about genetic testing for prostate cancer?
So there really are no specific guidelines regarding genetic testing. Now, the way that we typically implement genetic testing into the prostate cancer algorithm is really identifying men, particularly at a young age, who are diagnosed with aggressive forms of prostate cancer, particularly not so much for the patient's treatment plan, but ultimately for family members. So an example may be, and I had an example of this, where a patient in his early 50s was diagnosed with a very aggressive form of prostate cancer that we managed surgically successfully, but had 2 daughters in their early 20s. And so we had a conversation about checking for germline mutations and other risk factors that could potentially be translated into risk stratification for breast cancer, for example, in his daughters. And that's how I think genetic testing is utilized for the most part today, but no specific guidelines.
Thank you. Those are all the questions we have right now.
All right, well, we can summarize again at the end if anything comes up. So we'll move on to erectile dysfunction. You know, this is another really important topic because erectile dysfunction, it's a potential marker of cardiovascular or coronary artery disease, stroke, even all-cause mortality. And, you know, this is a potential opportunity really to identify at-risk patients prior to any adverse events. Additionally, eliminating, managing, or minimizing risk factors for cardiovascular disease has the potential to improve erectile function, especially in the younger patient population. You know, it's common that I see men in their early 40s that are presenting with maybe mild symptoms of erectile dysfunction, and we talk about, for one, establishing primary care. And this is common. A lot of patients that find their way to my office, this is the first time they've seen a doctor since they were kids. And you know, what's really important is that they are, you know, managing their potentially undiagnosed hypertension and hyperlipidemia and other cardiovascular risk factors. Now, the Princeton consensus has established a strategy of identifying men with erectile dysfunction who may require additional cardiac workup. And this starts really with assessing a patient's exercise tolerance, which is really just a proxy for assessing a patient's ability to tolerate sexual activity. And for reference, when I'm asking patients about their exercise ability, that's really what I'm getting at. Are they fit enough for intercourse? And so a couple of questions you can consider asking your patients, and questions that are often recommended in criteria like this are, can you walk a mile on a flat surface over 20 minutes? Most people can do that, but not everybody. That would be a reasonable way to assess someone's fitness for intercourse. Another question is, can you briskly climb up 2 flights of stairs in about 10 seconds? And again, you're getting at their underlying functional status. And, you know, I hope people can do a little bit better than 10 seconds. But that is some potential strategy and questionnaire that you can implement to really just risk stratify patients. But ultimately, you're going to decide, are these patients low risk, are they high risk, or are they indeterminate? And for the low risk patients, certainly acceptable to pursue treating their erectile dysfunction, and those with intermediate or high risk concerns should probably prompt evaluation by a cardiologist before prescribing medications. Now, the pathophysiology of erections is complex. It involves a psychogenic component. There are certainly vascular, neural, smooth muscle components to erectile function. Now, with appropriate stimulation, and just to give a little bit of biochemistry here, the nerve terminal releases nitric oxide, and this stimulates an enzyme called guanylate cyclase, which converts GTP to its active form, cGMP. And this is what really results in smooth muscle relaxation and ultimately an erection. And now, what's interesting is that cGMP is broken down to its inactive form, or GMP, and this is done by an enzyme called phosphodiesterase 5. And so this is the mechanism of action of the phosphodiesterase 5 inhibitors. It essentially keeps cGMP in the vasculature and maintains the erection. Now, a couple of key things here. It's important that patients have the appropriate arousal to initiate that cascade release of nitric oxide from the nerve terminal. It's also important to understand that an intact nervous system is needed to produce nitric oxide. So men that are status post a radical non-nerve sparing prostatectomy, for example, may not be the best candidates for phosphodiesterase 5 inhibitors because they may not have this intact neural pathway. Likewise, poorly controlled diabetics typically have some compromise of their neural pathway, and again, that may be why you're not seeing much benefit with phosphodiesterase 5 inhibitors. Now there's, again, many medical management strategies for erectile dysfunction that don't include really invasive surgery, and we'll touch on each of these. Now, first of all, there's evidence to suggest that lifestyle modifications are most effective in prevention and resolution of erectile dysfunction, but particularly when they're implemented at an early age, so before the age of 50. I have a lot of patients that come into my office, again, in their mid-40s with signs of erectile dysfunction, and they want to know, aside from taking medicine, is there anything that they can do? And the answer is yes. We know that obesity and metabolic syndrome are strongly associated with erectile dysfunction and low libido, and that weight loss can certainly improve erectile function. Men with regular, vigorous physical activity have greatly reduced rates of erectile dysfunction, not surprisingly, compared to men that are more sedentary. And a randomized controlled trial that looked at men with chronic stable heart failure who participated in at least 60 minutes of aerobic exercise 3 times a week had significant improvement in their erectile function. Now, when it comes to diet, again, the typical Western diet is generally speaking, not all that great for erectile functions or health in general. Men with a Mediterranean diet, again, have shown in studies to have lower rates of erectile dysfunction compared to men on a more typical Western diet. It's also important to consider medications when screening patients for erectile dysfunction, specifically beta blockers, thiazide diuretics, antiandrogens, antidepressants, SSRIs specifically, can certainly impact erectile function, and adjustments or changing medications can potentially improve erectile function. And then, of course, drugs and alcohol, again, an important question when screening patients for erectile dysfunction. Specifically, large amounts of alcohol can impact erectile function. What is interesting, though, is that there are studies to support that low amounts of alcohol, essentially the equivalent of 2 drinks, can improve erectile function, and this is especially true in men younger men who have psychogenic ED. Now, I'm asked about these a lot, and I'm sure you are too, over-the-counter and herbal supplements, and it's really hard to give patients an answer on this topic because there's really little regulation within the industry. The efficacy data on these supplements is often variable and of low quality. These supplements contain a combination of the nutraceutical agents I have listed here, but they may contain other elements such as Pde5 inhibitors. They may contain androgen elements. There's potential for other toxins or heavy metals. And so, generally speaking, I steer my patients away from experimenting too much with over-the-counter supplements. Now, really the safest place to start with medical management of erectile dysfunction is with the Pde5 inhibitors. This is the standard of care, really, of any etiology, and again, including psychogenic ED. Now, the available Pde5 inhibitors in the U.S. market include Viagra. This was introduced in 1998. Cialis and Levitra, they were introduced in 2003. These are all 3 available in generic formulations. And then more recently, Stendra in 2013. And we'll talk about these in a little bit more detail, but Cialis or tadalafil is approved in a low daily dosage for erectile dysfunction. Now, Cialis is structurally distinct from the other Pde5 inhibitors listed here and has a much longer half-life. And so the real strategy with a medication like Cialis is that if it's taken on a PRN basis, it provides a little bit more of a window for its ability to help a patient achieve an erection. Additionally, it can be taken at a low daily dosage of around 5 milligrams in effort to provide a little bit more spontaneity. And Cialis, as you may know, has been shown to improve lower urinary tract symptoms when taken at this daily dose. And so that's really advantageous. There's obviously a lot of our older patient populations who experience both erectile dysfunction and lower urinary tract symptoms, and maybe they're not totally optimized with Flomax. And so adding a low daily dose Cialis to their regimen can potentially benefit both causes. Now, there's a few key things to impart upon patients when prescribing Pde5 inhibitors. Number one, these medicines, generally speaking, should be taken on an empty stomach. Cialis is really the only exception to that rule, again, it being a little bit chemically distinct from these other medicines. But the absorption of these medicines is limited by dietary lipids, and so, again, important for preprandial dosing, generally about 1 to 2 hours before desired intercourse. And number two, sexual stimulation is key. The stimulation, again, is what initiates that biochemical cascade that leads to production of cGMP that was explained earlier. And so I often encounter patients who have been referred to me for erectile dysfunction, and they essentially say that the Pde5 inhibitors that they've tried in the past didn't work. And so before giving up on that class of medicines altogether, I think it's important to really understand that they're taking the medicines properly. So I try to paint a picture of a date night scenario for patients. Take the medicine at 5, you're eating dinner at 7, and it's in your system till around midnight. And I think that really helps the patients optimize their dosing. And what I don't want patients to expect is that they just ate dinner. They take the medicine, they're sitting on their couch watching Tucker Carlson, and they're wondering why they don't yet have a rigid erection. The stimulation component and the preprandial dosing are really key to the appropriate administration of this medicine. Now, men with concomitant hypogonadal symptoms, so low energy level, low libido, mental fog, depression, some of these typical hypogonadal symptoms may benefit from evaluation of testosterone deficiency. And in fact, that's recommended in the guidelines, really for all patients that are presenting with erectile dysfunction. The AUA guidelines recommend considering checking a testosterone level. And while certain patients may be salvaged by starting testosterone replacement therapy, I like to have a long conversation with my patients before initiating the hormonal workup, because testosterone replacement therapy can be tedious for the patient. There are potential and unknown risk factors associated with testosterone replacement, and often I find that certain men have no interest in going down that road, and so it's really a waste of time to do a hormonal workup if really the patient's only goal is to try to improve their erectile function. Now, with Pde5 inhibitors, there's really just one absolute contraindication, and that is nitrates that are prescribed for angina. This can potentially lead, as I'm sure you're aware, to life-threatening drops in blood pressure. And so for patients that do use nitrates and are still interested in management of their erectile dysfunction, it is reasonable in the right patients to consider still prescribing Pde5 inhibitors, but this should be done with great caution. Now, specifically, if a patient is prescribed a more short-acting Pde5 inhibitor like sildenafil or Viagra, the medicine for chest pain, the nitrates, should not be administered within a 24-hour period of the Pde5 inhibitor. And an even longer window exists for the longer-acting Pde5 inhibitors like tadalafil. But again, great caution should be observed when considering this for this patient population. Now, patients already taking alpha blockers, whether it's for hypertension or lower urinary tract symptoms, the dosing should be considered to start lower generally recommended at around a quarter of the maximal dosing and spacing the dosing of Pde5 inhibitors at least 4 hours apart from alpha blockers. Additionally, consider starting at lower doses for patients on CYP3A inhibitors or those patients with hepatic and renal insufficiency. Now, common side effects associated with Pde5 inhibitors include headache, facial flushing, heartburn, nasal congestion, cyanopsia, or the bluish hue to color vision that is typically thought to be short-lived and not a long-term consequence of Pde5 inhibitors, and then myalgia. Now, certain Pde5 inhibitors are less associated with cyanopsia, and more specifically, tadalafil is more associated with myalgia, but generally speaking, there's not one Pde5 inhibitor that's thought to contribute to more side effects as compared to others. And so what's important when you have a patient that may be intolerant or refractory to one of these Pde5 inhibitors is that you not give up on the class of medicines altogether. Consider switching to an alternative type before progressing along the pathway. And I have listed here, just for reference potentially later, the available Pde5 inhibitors in the U.S. market, both in the generic and brand names, the Tmax of each of the medicines, their associated half-lives, and then the dosing ranges for each of these medicines. And I'd like to point out that, again, Cialis, longer serum half-life around 18 hours. Most of these medicines are going to take at least an hour, maybe 2, to really be fully absorbed into the system, the exception really being Stendra, or the newest Pde5 inhibitor, which has the advantage of a shorter Tmax, which is thought to be around 30 minutes. Okay, vacuum erection devices, also known as the penis pump. And yes, this is a real thing. This is a real medical device, and it does work. These are available online, over the counter, and through various medical device companies. This involves a negative pressure chamber with a constriction band and is really best utilized, and patients have best success when they come in for dedicated teaching sessions, especially the patient and their partner. But these are really effective treatment strategies, especially for patients who may not be interested in more invasive treatment options but don't respond to Pde5 inhibitors. Now, some considerations for the VEDs is patient dexterities, patient anatomy, and then certain patients on anticoagulation. These may not be the best strategies for those specific types of patients, but it is, in general, an excellent treatment option and one that's often overlooked. Another consideration is intraurethral suppositories, the MUs. So this is a prostaglandin, PG1 specifically, that's administered via the urethral meatus. The first dose should be generally administered in the office because there's a 2% incidence of hypotension. The side effects include pain, burning and itching for both the patient and partner. Priapism is a technical side effect, but rare, and hypotension. And contraindications for this specific strategy are going to be patients that have known sensitivity to prostaglandins, those patients that have underlying hematologic dyscrasias, such as sickle cell disease, as this may increase their risk of priapism, and then patients with partners who are pregnant. Okay, intracavernosal injections. This is the injection of a vasoactive agent or a combination of agents directly into the erectile tissue. And these medicines are generally very effective and should also be first administered in the office setting, mainly to ensure that the patients are administering this medicine correctly, not just beneath the skin surface, but directly into the erectile tissue, and that they're administering it in the appropriate locations. These medicines are generally started at low doses, but can be easily up-titrated over time. And so side effects can include pain, although not typically pain from the injection itself. These are generally very small gauge needles, 23 or 27 gauge needles, and it's typically the pain that may result from the inflow of blood into the erectile tissue. Other side effects are priapism. Priapism is a much more significant potential side effect in patients on intracavernosal injections. Another consideration is fibrotic reactions, so scarring that can create length discrepancy along the sheath of the erectile tissue that can essentially create curvature with erections. So often we encourage patients to alternate sides when they are injecting these agents. And then bleeding or hematoma. Now, patients on blood thinner medicines can still be prescribed intracavernosal injections. We often just recommend that they hold a little bit of extra pressure onto the injection site after administering the dose. And then contraindications for this class of medicines, those with needle phobias, which is, again, not all that uncommon, believe it or not. Those patients with anatomic anomalies, other blood dyscrasias, like I mentioned earlier, with an increased risk of priapism, and then those patients taking MAOIs, and this is because of the risk of priapism. Patients that present with priapism to the emergency department, for example, the first treatment strategy for those patients is phenylephrine, and phenylephrine in combination with MAOIs can lead to hypertensive crises. Now, combination therapy, this is generally considered off-label. There's just the higher potential for side effects, and so can be a good treatment strategy for the right patients. Generally, this involves Pde5 inhibitors with the combination of either intracorporeal injections or the urethral suppositories. And lastly, since not all men are candidates for ED therapy or maybe refractory to ED management strategies or surgeries, this is an important consideration. They should be at least made aware that erectile rigidity is not necessary for satisfactory stimulation or orgasm, ejaculation, etc., and that they may benefit from referral to local sex therapists in the area, the patient and their partners, to get creative essentially with how they express their intimacy. And then lastly, I'll touch on experimental therapy. This may come up in your patient populations from time to time, particularly if they've listened to any of the radio ads about the men's health centers. The low-intensity shock wave, stem cell therapy, or the P-shot, as it's referred to, the platelet-rich plasma injections. There is some clinical data that is being gathered essentially at this point, and so there is interest in these therapies potentially, but really is not recommended outside of a clinical trial. And so, in summary, as far as erectile dysfunction is concerned, ED is a potential indicator of cardiovascular disease. Cardiac health should be assessed prior to initiating treatment and referred to at least a primary care doctor or a cardiologist if high risk is identified. Appropriate management of cardiovascular disease, and specifically diet and exercise, can potentially improve erectile dysfunction. There are numerous medical management strategies, as we listed here, that exist for men with ED, and so that is encouraging to patients to know that there's a lot of options. And then lastly, Pde5 inhibitors. These remain the standard of care in management of erectile dysfunction and can be optimized by taking a preprandial dosing and then considering alternative Pde5 inhibitors before treatment is advanced down the pathway. And so, happy to take any questions here. Any come through on the chat?
Yes,
that
we
we'd like
do
to
have
go
some
through?
questions.
Sure.
I missed a couple before, sorry.
Okay.
Forget to scroll down. What are the rates of incontinence and erectile dysfunction with treatment of prostate cancer?
That's a really good question, and that's something that again I discuss with all my patients in detail prior to committing to surgery, and those are really the two things that we consider long term. And now, what's important about erectile dysfunction after surgery is to really try to establish what is their baseline erectile function prior to surgery. Men with and we do that with the validated questionnaires that I give to patients prior to surgery. So I essentially can establish a score that can be monitored over time. But men who start out with very good erectile function can expect to have return to baseline of their erectile function after about a year, and with the administration of Pde5 inhibitors. So generally speaking, if the nerves to the erectile tissue can be spared during surgery, men can get back to their baseline erectile function within a year or so. And as it relates to urinary incontinence, what we typically see is that patients, again, continue to improve with time after surgery. Now, the rates of urinary incontinence after radical prostatectomy as an open approach as it was done many years ago are significantly higher compared to the more minimally invasive approaches that are offered today. So I generally tell patients that, that they will definitely have leakage of urine, particularly stress incontinence, in the first few months after surgery, but that typically improves over the course of a year or 18 months. And you know, there's probably only a 5% or less chance of persistent and bothersome urinary incontinence in patients after radical prostatectomy, so ultimately very low.
This was a question that I thought of too during your talk. The MRI for prostate, is that something that we as primary care docs can order? How hard is it? What kind of prior authorization do you need for that one?
Well, that's another good question, and you know, certainly in my practice, something that I'm trying to push the envelope a little bit. I discuss MRIs with really all of my patients when I'm screening for prostate cancer, because I know that they're going to read about it, and I want them to feel like they've had an opportunity to understand it and ask me questions about it before obtaining. Now, can a primary care physician order a prostate MRI? The answer is yes, absolutely, but I think it's important to understand and to stress to the patient that MRI of the prostate gland is not a substitute for prostate biopsy. It is just an adjunctive screening tool that can kind of help in the decision-making process. So I don't use it as an alternative to prostate biopsy. I use it just to help risk stratify patients, and so there's a couple of things that should be noted if you're going to order an MRI of someone's prostate. There are specific imaging centers in the area, specifically imaging specialists in Mount Pleasant, that offer a multiparametric prostate MRI that is intended to be used as an adjunct to prostate biopsy. So they use a specific imaging protocol. So I would make sure that you're, you know, ordering you know, the correct test first of all before committing a patient to that. But absolutely, you could consider that.
There was a question about revascularization for ED.
Yeah, good question. Now that is, you know, there's limited data on that, I'll say, to be sure. Now, in patients who may have had prior trauma or injury to cavernosal artery, for example, or you know, pudendal arteries, there may be a role for revascularization, but as it relates to the average patient with you know, peripheral vascular disease, that's really not an option.
It certainly doesn't do much for small vessel disease.
Correct.
Yeah. Some comments about lifestyle choices. Vegans have better erections. Another idea is the dosing of Viagra. There are some studies that have shown using 200 milligrams. Is that something that you've considered or do?
Well, what's interesting about the dosing on medicines like Viagra, the Pde5 inhibitors, is that at least in clinical trials, you know, this was a medicine that was initially designed to treat hypertension, and what they found was that men were reporting significantly improvement in their erectile function, and so that's how this class of medicines took off. But the dose ranges are generally between 20 and 100 milligrams for sildenafil specifically. What they found in clinical trials around this medicine for erectile dysfunction is that as you increase the dose, the efficacy as far as erectile function is concerned tends to plateau around 100 milligrams. But the side effects increase. And so I generally don't prescribe much more than 100 milligrams of sildenafil specifically for that reason.
This question I think is very germane. Recommendation for a sex therapist. Just recently I was trying to find one for a patient and ask one of our urology groups, and they had no idea.
Yeah, that's a good question. There is, so this is you know, not a situation that comes up a lot for me, but it has within the last few months. And so there is a group in the Mount Pleasant area. I'll have to, maybe I can look that group up specifically, and we can figure out a way to distribute that information. But
we would love some
there's
information
a handful of clinicians with that specific focus, and believe that they are located in the Mount Pleasant area, but I'll work on getting that information to you so we can distribute that.
And we'll distribute it to everyone, because that is a big issue. People ask, and you don't have any place to send them.
Right. Yeah. Right. I think that patients, you know, when it comes to things like that, the more comfortable you can converse with patients, and the more familiar with that pathway you seem, the more comfortable they're going to be with implementing that as a strategy. So good to have some names and numbers for that. So I'll make sure to get that to you.
I've heard this too, that testosterone in itself doesn't really help the ED. It's more for the other symptoms of low testosterone. I think you spoke a bit to that, but do you think testosterone helps with ED?
Yeah, I think that there is actually evidence to support that you know, men with a testosterone deficiency who have concomitant erectile dysfunction will potentially benefit in terms of their erectile function when prescribed testosterone. And so again, as I mentioned earlier, what I have found though is that when I discuss the treatment pathway for testosterone replacement therapy, that really either seems like too much of a burden for patients to take on. You know, it requires a lot of office visits for one, lab work, titration of medicines, additional prostate cancer screening, all of these things. And so what I've found is that a lot of patients don't really want to commit to going down that pathway, at least initially, and instead prefer to focus strictly on management of their you know, erectile dysfunction.
There were a couple of other questions following up on that. What about the younger patient with a low free testosterone and low testosterone? What is your approach to them and their fertility?
Yeah, another really good question, and something that comes up a lot. So, you know, again, I think it's important for patients to understand that you know, hypogonadism is a manifestation of symptoms, and certainly can be related to testosterone deficiency, and is related to testosterone deficiency. But in men who are just concerned about a low testosterone number, but ultimately do not have any hypogonadal symptoms, you know, I really don't encourage treatment of that. Now, in men who are truly hypogonadal and are interested in treatment, we think of alternative strategies outside of testosterone replacement. Specifically, we sometimes implement the off-label use of the medicine called Clomid, which is in the classification of Serums. And the way this medicine works is it essentially blocks the feedback mechanism to the brain, and the brain essentially is not able to sense these breakdown products of testosterone, and it ultimately sends more signal to the testicles to produce more testosterone. And so you can preserve a patient's fertility while increasing their testosterone levels in that manner.
When someone's getting testosterone transdermally, how do you follow them? Are you using serum levels, or are you checking just their symptoms? Yes,
so both.
Okay.
The answer is both, yeah.
And another question I practice in Mount Pleasant, and we have hormone centers on pretty much every corner.
Yeah.
Are there any concerns that you've had about the standard of practice for these centers, and things that we should share with our patients?
Yeah, especially the younger patients. You know, I have seen a lot of patients come into my office that are otherwise young, healthy males in their early 20s or early 30s who have heard the advertisements, and I don't mean to disparage. I think that these centers, you know, are probably doing their best to offer patients good care. But you know, I've found that certain patients may end up on testosterone replacement therapy when they don't need it, and without the counseling, that this could potentially affect their fertility, and without the counseling, that when they come off of the medicine, that they are going to be hypogonadal, because the whole hormonal axis has been shut down by exogenous administration of testosterone. And so I generally tell my patients that, for one, you don't need it. It is very rare for younger men to present with hypogonadism. That does exist, but I do have the same concerns that you expressed about some of the centers in the area potentially targeting patients for that reason.
Yeah, I think we all worry about that, and whether they really are checking PSAs or serum levels or other things. And so maybe as a primary care doc, you need to ask. I often will get their lab results just to see if they've checked.
Yeah, absolutely. I would say that if you have a patient on or that's plugged into one of those programs, that you should be keeping a close eye on things and just assuming that some of those things are not being done.
Yeah. Well, thank you. I don't see any other questions. Let me just look one more time, because I'm bad about that. Of scrolling down. Yeah. I really appreciate your time, and it was a wonderful talk. We've learned a lot from your discussion. We will get out information to everyone about the sex therapist in another mailing or email chain. Right.